Welcome everyone to the PFCC Partners Community of Practice Workshop for March of 2022. Thank you all for joining us today. My name is Lindsay Galley. I'm the Director of Education at PFCC Partners, and I am very excited for our workshop presenters today. We will be hearing about a new tool developed, or I should say co-designed, with Cynosure, hospital quality improvement contractors, and patients and families called Layers of Protection for Patient Safety. We're joined by Kim Workmeister and Nadine Alexi, who will be talking with us in just a few minutes. But first, I just wanted to introduce our organization. Our mission at PFCC Partners is to center the inclusive human experience of health, reinvent through radical collaboration, and be a catalyst for system transformation. And by focusing on that mission, our goal is, and our vision in the next 20 years is a health system transformed, one that works with people and through communities as a partner in their well-being. We create spaces within healthcare for patients and families to actively engage by really living up to the values that you can see on your screen here. Equity, providing a brave space, resolving the healthcare challenges of today. Inclusion, creating belonging for all people and all communities. Diversity, differing perspectives are expected and respected. Collaboration, equitable and shared decision-making power. And finally, solution focused, acknowledging challenges only to resolve them. And we fill those spaces that we create in the healthcare environment through the PFA network, which is a community of patients and family caregivers, all serving in the role of patient family advisor or patient family partner, really focusing on these three areas: engagement opportunities, so providing opportunities for patients and family caregivers to engage in healthcare, using their lived experiences to help inform improvements within healthcare, by creating a community, which is really a diverse network of patient family advisors that are all bringing their voices to see the change that we all want in healthcare. And finally, skills development. We facilitate learning so that patients and family caregivers can become an impactful and effective partner in change. So that is a little bit about our organization. I see that a lot of you have already chatted in to introduce yourself. So if you haven't done so already, please take a moment to do that while I introduce our presenters. So today we are joined by Kim Workmeister, who is Senior VP of Improvement and Implementation at Cynosure Health, and Nadine Alexi, who is the Cynosure HQIC Patient Family Partnership Council member, and they are going to talk to us today about a new tool developed called Layers of Protection for Patient Safety. And with that, I am going to pass it to Kim and Nadine.
Great. Thank you so much. Let me pull up my slides here real quick so Nadine and I can get started. But thank you very much for the opportunity to talk about some of the processes that we've put in place in it's a government funded project called HQIC, which is a CMS project aimed at about 1,500 hospitals nationwide. We're one of 9 contract awardees for that, and in the Cynosure Convergence HQIC, which every government project has a different 3 or 4 letter acronym. This just happens to be one of those. We have just slightly over 300 hospitals that we are working with, and I think that I've been in quality and patient safety for probably 20 years now. And I would say it has taken 20 years to get to the point where we are now. And I hope that by sharing the stories from Nadine and myself, our experiences with this, you'll maybe get as excited as I am about this partnership that we've been able to really meaningfully develop together, and something that it feels like we finally got that secret sauce there here. So briefly, I just want to make sure that we give, I want to make sure that Nadine has an opportunity real quickly to introduce herself and her experience and her role in this partnership that we have together. So Nadine, do you want to just give a quick introduction of yourself to those who may not know you?
Sure. And Kim, can I tell you, it's such a privilege to be part of this today. Of course, I'm tickled. My career was really in IT. So of course, I love to audit websites and things like that. And I'm very graphically inclined when it comes to patient facing materials. That's really my love. And Cynosure has really let me embrace that. They really take the time to learn people's strengths and even pull other things out of people that they don't know they've got locked in there. Some nuggets of information that could be so critical to changing the face of healthcare, you know. And I'm from Chicagoland, and really the big catalyst to me getting involved in anything at all in this regard is I visited patients for over 10 years at 3 area hospitals, and the things they tell you that they don't tell clinicians is eye-opening. And that was really the catalyst for me getting involved in patient family advisory councils at the local and national level. And then of course, interacting with Cynosure. And I've got to tell you, they've really given this team that I'm on the freedom to really invent things. And you'll see by the documents you're going to be seeing, the tool, just how willing they were to let us come at it from our perspective, and totally respected our opinions.
Thank you, Nadine. I will say the exact same thing, that it is such an honor for me to have this opportunity, and really just an honor to be part of this partnership here. And just briefly, you heard I've been in quality and patient safety and in the hospital kind of level and at the national level for about 20 years. I'm a nurse by background, and was that person in the hospital for many years who I had the job responsibility for ensuring that we were engaging with patients and families. But unfortunately, that was, a long time ago, before we got good at it at all. And I frequently talk about how I'm frankly embarrassed by the way that we really didn't embrace the opportunity that we had at that time. And I'm so glad that things have changed. So with that, let's get moving a little bit. So I wanted to start with a couple of questions, some for the folks that are on the line that are patient family partners that are not healthcare professionals, and then I have another question for those that are in the healthcare setting. And I don't know if these are actually set up, Lindsay, as an actual polling question. No, okay, good. So we can just use the.
Kim, I have a poll set up, but the responses don't match.
That's fine. That's fine. Let's just do this. No need to do an actual poll here. If you could just chat into the chat box, I would love to hear, for patient and family partners, as a patient family partner, how many times have you been invited to participate in a hospital or healthcare organization-based quality improvement initiative, or even in the development of a resource? Never. Maybe you've been invited, but the timing didn't work out. You've been invited and you participated once, or you've been invited and have participated lots of times. I would love if you could just quickly just put that in here. Okay, we're seeing a few back and forth here. It looks like it's either never or many times, pretty much. Okay, good. Okay, so we have a variety here too. And I'm going to be, for those of you that have participated more than once, I think as we go along, and we hope that we'll actually start a real good conversation here at the end. That shouldn't just be a presentation the whole time. Please speak up. I would love to hear about your experiences and how those of us on the healthcare side could improve the way that we approach this. And so the next question then is for those that are in the hospital or healthcare organization side, our team members there. So as a hospital or healthcare organization, how many times have patient family partners, to your knowledge, been invited to participate in a quality improvement initiative or the development of a resource? Never, to your knowledge. Maybe you tried it out, it didn't work out. You tried it at least once, or more than twice. So we have here. Getting a variety here too of never, at least once, more than twice. So yeah, it runs the gamut here. And I will tell you that is not uncommon at all from what the work that I know I get to do on my end. And I know that Lindsay would agree too, that it does kind of run the gamut. But those who have been able to figure out how to do it meaningfully with multiple times over, I think we'll say the same things that I'm saying, that it has been such a rich experience and nothing like I thought it was going to be. All of the fears that I had about it certainly gone away and gone forever with this. So I'm wondering, just with this, then we can just take a moment, and I know everyone you can just unmute your line to speak up if you'd like to. For those that answered in the affirmative, either from the patient family side or from the healthcare side, what was the experience? What has the experience been like to have patients and families being actively participating in quality improvement activities? Or more specifically, what about that experience was successful, or what about that experience was unsuccessful or challenging?
Well, I'm going to speak. Go ahead.
Go ahead, Nadine.
I'm going to speak two things. I'm going to say it was really wonderful to see some suggestions made, or as time went on and they got to, respect the value of the team members that were, lay people like me. And then to come back, and you guys are very good at this. You really let us see what you're enacting of what we've presented. That doesn't happen a lot, but when it does, it just really spawns you to get more and more engaged, and then they build that trust, and then they engage you more. So it's kind of that, if they don't come back to you and show you what you presented was plausible or not, you'll never learn to know the system, I'll just say generically, so that you're a better patient advisor member.
Exactly. Oh, this is good too. Okay, and there's some great comments in the chat too. So Peggy, who I know in Montana, I'm thrilled that you're here. Says our patient and family advisor has been very helpful, pointing out where we can improve, sharing their thoughts about new services, nothing but valuable info. Excellent. And then Ken says, 2 were very successful. PFAC ended up being a focus group, not a council, and not like an advanced council. That I can see how that's incredibly frustrating too. I thank you for sharing that then, Ken. And then Pat, it's hard for group to see that that parents, and I'm assuming also patients too, also have degrees and experiential knowledge. Yes, exactly. And how can we start to learn about, the folks that we're partnering with, what their knowledge is like? Barbara, I see your hand raised. Did you love to have you share too?
Yes, I echo what Nadine was saying. I think as a patient family advisor, initially the invite might be kind of perfunctory. We have to have a patient on the team, and they don't know what you can offer, and you don't even know what you can offer. But if there's at least a willingness to sit at the table together and to listen to each other, wonderful surprises emerge, and you don't always know what the specific value is that you'll bring. But it might change the direction of a policy. It might change the direction of a practice. It might introduce something, an innovation that was just never even considered as part of the parameters. And I think very importantly, patients are embedded in their community and are aware very often of not just community issues, but community resources. And we can make those connections from the community back to the organization.
Exactly. Thank you so much for sharing. There are a few other great comments in here. Lori says our PFAC is so valuable. We do focus groups and committee work and process improvement. So you run the whole continuum there. Have had families involved with building design. Incredibly powerful to have the voice at the table. Stephen, essential infrastructure supports high value partnerships. Yes. And then Lindsay, just so many great opportunities to Lori too. Yes, agree. So wonderful. So you see, I think we're all on the same page here, but wanted to just give you an example of how this has worked in this group that we have been so lucky to get to pull together. And the secret sauce that we found now for meaningful engagement. Now, the recipe is going to have to continuously change because that's the way this works. And if we think that we've got it right now and we just stop, well, we're not doing what we should be doing. We can always improve it. But for what we know right now, here's how it works for us. So in that Cynosure H-Quick program, we have a little over 300 hospitals that are from all across the country. So the states that you see highlighted are where our hospitals are. And we want to make sure that just as different as every single hospital, every single region is, that we have patient voices that represent all of those populations then too. And PFCC Partners, who's been such a fabulous partner with us, has really made just every effort possible to ensure that that happens. And the reason for that is that, we have each hospital is only each hospital. So within all of those states, as you can imagine, we serve a variety of different kinds of hospitals, some very, very tiny critical access, super rural community hospitals, all the way up to giant behemoth university setting hospitals and everything in between in here. And within each one of those hospitals, that they serve, the population they serve is very different. No two hospitals are the same. No two populations served are the same. And then within each of those hospitals, we know that our staff and everyone who's part of the organization comes from completely different backgrounds too. And that gives us a lot of room for potential challenges there. If you have been part of anything with PFCC Partners in the past, you have probably seen this analogy here too, but we have fully embraced what they have taught us is the funfetti approach to combining all of those different viewpoints and experiences and lenses into the funfetti approach to meaningful engagement with each other. And that you can imagine what that means with, you're making a funfetti cake. That means you're taking all the different sprinkles, you're taking all the different colors, all the different, if you have different flavors of sprinkles, they're all together. And you know what? They make something really incredible. To me, I don't know if you like cake and sugar, which I clearly do, but they make something really, really incredible. And that's what we've been trying to do. But that still just because it's this fun idea that we have doesn't mean that it's been easy and not challenging at all. Because once again, every single hospital has a lot of different challenges, a lot of local challenges, and all of the patients that they serve have very different challenges and strengths and needs and wants. And so we've done a few things that we believe has helped us to take the first main point of this, and that's building trust with one another. And we had a large conference with all of us together last summer, and there was this great quote that came out of it that I think all of us have remembered since then, and that's that improvement happens at the speed of trust. And when we heard it, I saw folks, and it was a virtual conference, but you could see eyes going, oh my gosh, yes, you're right. And it is true that, in order for us to partner together and to actually have improvement and things get better, we have to trust one another. So the question then is, how do we build trust with our teams together, but then also at the local level, in the hospital level, how do we build trust with one another in these short little instances that we have together when, you might have someone, not even the medical personnel, but all of our other folks. How do you get trust with the dietary folks that come in? How do you get trust with those in, radiology or whatever? It's so short. And so what we've done is, well, first we wanted to say that there are things that happen when we're communicating and trying to build trust that, sometimes they work the way that we think they're going to, and sometimes they don't. So I have a quick little, make sure I share the sound here, just a short video clip to demonstrate what sometimes happens when you are trusting you.
Fall, and it'll be an exercise in building trust between one another. So Harrison, if you don't mind going first, step up here on this chair and close your eyes. All right, and then everybody fill in, and we're going to ask you to fall, and then they will catch you. So you have to trust us. So I'm going to count to 3. Just relax and fall. Okay? 1, 2, 3. No, wait, no.
And I think we have all we've all experienced that feeling of, yeah, I'm going to trust you. This is going to work out great. And then it doesn't. So again, we are working really, really hard to ensure we're not falling flat on our faces when it comes to building trust, but we're doing things that really actually are helpful in building trust. So we had to learn to speak a common language with one another. It's really, really easy, especially for, for me as a nurse, it's really easy for me to have this assumption that everyone understands the acronyms that I'm using. Everyone understands the exact struggles that happen when caring for patients. And it's difficult for me to understand exactly what happens from the patient and family perspective when that nurse is at the bedside too. And so we have to, we had to really do some things very specifically to build that trust and to start to understand each other and speak a common language. So we weren't just constantly filled with these, garbled information and everyone thinking they're doing the right thing by communicating, but just not being effective at it. So there are a few things that we have put in place. First is the knowledge that we have to know why others care about this, why we care about it, and why others do when we're trying to partner together. We really had to learn that people don't actually care what you know until they know that you care, and that onus is really on my opinion. That's on us as healthcare providers too. That if we want patients and families to meaningfully partner with us in this work, they have to know that we're not doing it just because, well, our accrediting body says that we need to have a patient on a committee or we need to have this. It's because it's really important to us and we actually care what what we're going to hear about too. We want to use it to make change. And so as clinicians, that means a lot of things to us. We have to learn to leave our, our egos, our implicit bias. First you have to understand that there's implicit bias, our explicit bias too. I know this isn't news to anyone on our patient family partnership council that a lot of our clinical team was like, oh, I don't think patients know what we're going to be talking about. I'm not sure that they're going to be able to add the kind of insight that we need to have them add for these educational webinars and things that we're putting on. We certainly know now that is not the case, but I will tell you that's a common explicit bias that we have, and just kind of a tendency to think with a clinical lens at the door. And then we had to move beyond even where we started, which was, okay, fine, we'll start inviting our patient family partnership council members to some of the webinars that we put on for hospitals. So we're, there'll be panelists here, but we didn't do a great job of it in the beginning. We just said, sure, come join. And then we'd get to the end of the session and then would say, oh, Sally, do you have anything you want to add? We have 4 seconds. That's not the way to partner with anyone. So we had to learn to be actual partners. And so we did some really specific things to build these relationships while we were partnering. And first is on this left-hand side, we developed something called the Meet Me pages, which were really, this was kind of like the idea of baseball cards. So our clinical improvement advisors and our patient family partnership council members, we all had our Meet Me baseball cards made. And they were the same. There were pictures of us. It was, what our names were, but then most importantly was, why is this work important to me personally? What kind of areas of expertise do I have? What areas do I really want to focus on? And then, things about us personally. So we got that piece in place. And that was really interesting as we started reading through and, oh, wait, I had no idea. Look at the things we have in common. And oh, I'm thrilled that specifically there is a patient family partner member who is really interested in reducing readmissions, which is my role for our project. So I'm thrilled with that. Then we started pulling together some events from the improvement advisor side, for the quality improvement. We every single event that we pulled together, we then started purposely selecting a patient family partner to participate, but not the way we did in the beginning, by having them be part of the conversation from the very beginning and saying, okay, let's talk through what would be helpful. This is the problem that we're trying to solve. This is the issue we're trying to improve. What are your thoughts on this? And starting from the beginning with that. We also, of course, have these PFCC Partners puts on the fabulous think tanks once a month too, where we bring everyone together from hospitals and patient family partners to really talk through other ways that we can do these things in a more meaningful manner. And we've been able to get to the point where, if you see on we had a fall series of events where all had a football theme. Then we had an adverse event. One of the focus areas was on adverse drug events, and specifically hypoglycemia. That group has now morphed into such an incredible partnership together, where we're developing patient activated tools in order to decrease hypoglycemia related adverse drug events. So flipping the script completely from, okay, what can the nurse and the physician do? What can we put into the EHR to, hey, here's an idea. If we're talking about diabetic patients trying to prevent hypoglycemia, I can guarantee you that patient knows far more about when they are starting to get into a hypoglycemia event and what works for them. Let's harness that and let's develop something together so that we can have a patient activated. We're doing the same thing with sepsis too, and with pressure injuries. So we're really now trying to move beyond just what can the healthcare team do based on what we've heard from patients and families to, hey, how can we really work together to do this? And so that brings me to the tool that I wanted to share today and just walk through the experience that we had here that really highlights, I think, this funfetti approach in action. And so many of you might know that throughout the course of responding to the COVID pandemic, the CDC came out with, there's been, a lot of literature from the CDC and others about the effect on COVID surges on outcomes for patients in hospitals, not because of COVID, but because of the fact that we had chaos and this emergency, this ongoing constant emergency. So hospital-acquired infections went up significantly. Readmissions kind of went up and down depending on whether or not elective surgeries were being held. Pressure injuries went up significantly. Sepsis mortality went up significantly. And again, not just among COVID patients, but in the chaos of everything. And so what our clinical team did is we wanted to find out a little bit more about what it was exactly that drove these horrible decrease or horrible increases in adverse events occurring. And so we held focus groups with dozens and dozens and dozens of hospitals that we work with the subject matter experts that are there on the front lines telling us, well, let me tell you what happened. And we learned some things from them. And then we said, okay, so knowing that we're going to have an ongoing staffing crisis. I mean, we're luckily COVID numbers have gone down significantly in most areas, starting to maybe creep up again, but staffing challenges are still there. So what in the face of that would you recommend to peers as some sort of guardrails for preventing this kind of backtracking from happening again? And they gave us some really, I don't want to say easy, but pretty practical, simple things that even in the midst of chaos, that hospital staff can implement in order to prevent some of these issues from happening again. So, I think the best example was with the increase in central line associated bloodstream infections, or CLABSI. What we found from talking to infection preventionists and talking to, the critical care nurses and physicians and everyone in the field is that, well, we were so busy, we were keeping patients in lower levels of care for much longer than we ever would because there was no place for patients to go. We had a lack of PPE. And so a lot of folks were not really interested in inserting central lines in the neck area here where you normally would. We wanted to be as far away from specifically COVID patient faces as possible. So they were inserting them in the groin. We had lines and tubes that went all the way out the door because we had to restrict the number of times that healthcare workers went in and out of a patient room. Just a lot, which also had the potential for introducing infection. There's just a whole lot of things like that. And we learned things about that for all of these topic areas. So once we had that, we decided we wanted to build a resource that we called Layers of Protection. Now, we developed this right before winter of this year. So we called it Winter is Coming, Layers of Protection for Patient Safety. And as you can see, it was done in a really tongue-in-cheek manner where each topic had a specific layer. So that might be actually a hat going on a patient. For readmissions, it was boots. For catheter-associated urinary tract infection, it was. So, and we just, on this patient here, we layered on protection. And those were those really basic, specific, practical ideas and strategies for hospitals. Now, with this funfetti approach that we have, we wanted to make sure that we did practice what we've been preaching. And so I had the wonderful opportunity of going to set up a time to meet with our Patient Family Partnership Council and with our hub, which is another like larger group too within our HQIC project. And I went to them with the idea that I was going to ask for specific advice for each of these individual topic areas from a patient lens about what hospitals could do, what additional things hospitals could do in order to prevent this backsliding for each of these topics. So I expected to hear that. And again, you would think that by now I would know, don't expect what you think. Go in with an open mind. And I'm glad I did go in with an open mind, but my expectation was still there. What I heard instead though, and I am so thrilled that because we have this trusting relationship together, was every one of those council members said, Kim, no, you don't have it right. You don't need specific guidance for each of these topics from us. What is most important for patients and families is that you build that structure over them. So in this tongue-in-cheek patient all bundled up with each layer, let's make sure that we strengthen that actual structure around them. So in here, it's like a cabin. And what that structure is that the keys to creating the safe environment for patient-family engagement, keys that really create an environment that encourages patients and their family members to speak up. And we very purposefully, they told me, and we did it verbatim so Nadine will be able to tell you verbatim, these are her comments and comments from others about what each item in the room might represent when it comes to really building this relationship with our patients and making it a safe place for them to speak up. So maybe it's the curtains, pull back the curtains. Don't make anything a secret for patients. Stay connected to them. You see where the light is plugged in. Shine a light on the patient's willingness to engage. This is great that you are. Don't couch big issues. Let's talk about it. There's no reason to have any of these things be a secret or anything to be done in silos. If we can make sure that our patients and our family members are truly empowered to speak up, that's better for all of us, and that's going to help us reach this level of safety that we've unfortunately had to go away from. So, it was a really humbling experience for me, which every day is, but this was a great humbling experience because I once again got to see that, wow, even when I think I know what this engagement together is going to mean, I have to leave my ego and my expectations at the door because otherwise I missed the richness here. Nadine, do you want to jump in too? I've been doing all this talking here.
You bet. Maybe this time I didn't have to raise my hand because I'm a co-presenter, but I have to tell you, it couldn't have been more inviting of a exercise, I'll say, because even though we saw the preceding pages, how it was kind of tongue-in-cheek, we were not given any direction. I mean, I just sat down one day and I just filled things in, so much so that the one with the rug, I thought that was a hole, like a sewer hole. I kind of lost the perspective of it being a house. I mean, all the other ones just kind of came to me fairly quickly. So I had to rethink that one just to offer a bit of silliness here. And then when it came to the environment side, like one thing I listed was you've got to like maybe draw on the discharge papers. It just might hone in on something that'll really get through to them so they don't come back in the hospital. You don't have that recurrence rate and little pain and agony and stress that goes with all that. So it was really a fun exercise. And the main thing I want to say to you is we were given complete freedom to design this anyway. They didn't change one word that I wrote, they being Kim. And it didn't have to play out that way. That's not what I was looking for, but evidently they just really trusted our approach to this.
Exactly. And I've been able to share this across the country now too, with the other HQIC contractors, with the Medicare, with CMS, with the federal government, everybody. And I make sure that every single time that I present it, I say, these are this is the verbatim advice from patients and families, from our experts. Do not change them, because this is what's most important. This is what they're telling us. And if we're really practicing what we preach, then we're listening, and we are taking advantage of making sure that we're putting those words there in place for everyone to know. This is just another way. I forgot that I put this here too, that we have to really be willing to listen to what really matters to our patients and family members, and that our expectations are not their expectations, and they really want to partner together with us. So our job on the healthcare side is to empower that partnership, because there is definitely a power paradigm here. It is, when you come into the hospital, you are completely at the mercy of those that are taking care of you or taking care of your family member. And I have had the opportunity to be on that side of it too. A few years ago, after a traumatic accident for a few of my family members, spent 2 solid weeks at their bedside in a hospital that I wasn't familiar with. But I will tell you now, I am the chair of that PFAC because of that experience, and seeing what this can look like in a meaningful way too. So, it doesn't always have to be tongue in cheek or be a cartoon look at it, but just really knowing that if we take the time to listen and put our preconceived notions away, there's so much richness that comes out of this. And one of the points that our council members said to me, and this is another verbatim quote, when we were talking about how challenging it is to be a healthcare worker these days, how challenging it is to try to do anything in the hospital. We know that we have lost a third of our workforce, and then another third is kind of transient now, going in and out, either registry or traveling contracts. It's hard. It's really difficult in the hospital. And while I was trying to say that, one of our council members said to me, Kim, just let others know you don't have to sugarcoat it for us. We know you're stressed. We know you're short-staffed. Just be transparent and empower us to speak up when something doesn't seem right. We know that we're going to have challenges getting our call lights answered. We know that there aren't as many of you as there were before, or you're newer. That's what's going to continue to make this partnership work, and for us to be part of the team that helps to prevent errors from occurring too. And so, Nadine, I want to give it back to you again here too. I'm wondering if if we have some pearls of wisdom from the patient-family partnership perspective, what advice would you give to healthcare personnel who'd like to more meaningfully engage with patients and family members in quality improvement? And maybe as a follow-up to that too, what strategies might healthcare personnel utilize to empower patients and families to speak up and engage and feel like they're true partners in this work?
Well, I'll kind of meld the two together. It's just like you said earlier, we're not just a check mark. Okay, we know it's an integral part of healthcare now. We have to engage patient and families. But if you just start with one small thing, like I was asked to look at all the bathrooms in one hospital, and I made like 7 suggestions, and they took 5 of them. And they may seem like little inconsequential things, but it's very rewarding to have, see your thoughts in action. But that's not my point. It's that the clinicians can see that you really have a perspective they would never even think of, because they're so concerned about healing the patients and making sure they don't come back. And then you build on that. you get that mutual respect thing again, and then you're not an afterthought. You're like, oh, yeah, we should really involve that group, and let's see what they have to say about it. And then it becomes a regular thing, and then they give you meteor projects. Like I worked on the CARE Act, which was a legislative thing that was rolled out nationwide. Pretty much most states enacted it, and they literally had me in every step of the way in that project through to completion. And it's like anything. Once you're accepted and once they see your value or your strengths or weaknesses, then that's how they use you, is not the right word, but involve you. It takes time to grow. I will say, get some early wins and show that you're dedicated is one thing, but once they really see some difference in processes and patient satisfaction, then there's no stopping them.
That's right. That's right. How about others on the line then too, that are from the patient-family partnership perspective side? Any advice for those of us in healthcare about how you would recommend that we start to, the very early steps of building trust among one another? Any advice for us there?
Hi, this is Precious McCowan, and one of the roles that I play is that I am an end-stage renal disease patient advocate. And what we've noticed is that a lot of times patients are afraid to speak up because they're afraid of retaliation. So we developed a tool for both patients and the dialysis staff that talked about retaliation, what it is, and also ways to kind of resolve conflict amongst each other so that a grievance wouldn't have to be filed. So I think it'll be important to kind of speak to that as well.
Yes.
And yeah, because a lot of times patients, we see things that are wrong, but we like, well, I just let it pass. I don't want to be mistreated. I know that they are stressed out. So, I'll just be quiet. I won't say anything. So I think that's important to address as well.
That's so important, Precious. I'm really glad that you said that too, because I will tell you now, from just as a nurse, it is helpful to know if a patient says, okay, I mean, just even the bare minimum of, wow, that doesn't look like the tubing that's usually used for me. That doesn't look like the pill that I usually take. Just even those questions help us to say, oh, wait, did I potentially grab the wrong thing? I mean, we're partners here in this. I thank you for doing that. Barbara, I see your hand raised.
Yeah, I find that when I'm at meetings, people talk at 150 miles an hour, and they're very involved in the topic or in solving the problem, and it's hard to create an entry point. So I think if the meeting has a leader or a facilitator, if they could deliberately stop and make space for the patient voice to enter, that would be extremely helpful. And that could be as simple as saying, we've been talking about X. I'd like to hear from Nadine what she thinks about that.
I love that's such a simple, practical advice too. Those are the kinds of things where, just like I know I'm guilty of it. I talk really fast. I get really excited about what I'm doing, and then people have a hard time getting a word in edgewise. If I could remember to slow down and think through, okay, I'm going to stop, and now I need to ask somebody else for their input too. That excellent advice. Anybody else have some advice from the patient-family partnership perspective for building that trust and really creating that meaningful engagement? Should look and see. It looks like there's things coming into the chat. We make sure we share examples of how the family voice influence changes. Oh, that's excellent too, Lori. Thank you for sharing. They have a newsletter for all their electronic advisors in both English and Spanish. Excellent. Great.
Yeah, and that actually came from another question that said, how do you empower patients or families that culturally don't normally think that their advice?
Oh my goodness, yes.
Important. So anything.
That's such an important question too. I'd love to hear anyone else, if you'd be willing to unmute your line, about how you have meaningfully, really included and engaged different voices and acknowledging cultural differences because it helps set a foundation, creating transparency. Yes. And some of the things that I know that we've been trying to do within our HQuick too is purposefully go, looking for patient family advisors that have the same, that look the same, speak the same, have the same cultural backgrounds as the patient population that we serve too. There's no reason that I certainly don't represent, I represent my little community, but that's a tiny community. So I really appreciate the fact that we're learning from PFCC partners in the way that they're really purposeful in this too.
And Kim, whether it's related to diversity or not,
Mm-hmm.
that just brought it to top of mind. You really have to get team members, patients, whoever you're interacting with at whatever level, really encourage them to speak up in the way that you would say, could you rephrase that? And I'm not even talking about acronyms.
Mm-hmm.
In every walk of life, I just, I'm always asking what's your name. I can never remember names, but it doesn't stop me from asking 50 times. But if you just ask whoever is the presenter or the clinician or whoever, could you please rephrase that? Otherwise, you could be going off on the wrong tangent, whether it's trying to add something to the contents of a meeting or your own healthcare.
Yes, exactly. That reminds me of the one of the things we always talk about when we're talking about reducing readmissions and ensuring that patients and their family members or caregivers understand the instructions for how to take their medication once they're outside of the hospital. And a lot of times we say, take this with meals. Well, what does that mean? What if you eat 6 meals a day? It's so that's I totally agree. Lana has a good inclusion, can be asking all to share based on their experiences. Excellent. Ken, I know people on a hospital PFAC where members of the PFAC are allowed to go on rounds. And what they found is that patients might be afraid to ask or don't understand, but would open up to the patient who was on the team as they felt more comfortable reaching out with the questions to them to help resolve the question. Thank you. Ken, I will tell you, as the readmissions lead for us, one of the main takeaways that we learned from hospitals that have been able to reduce readmissions is that they have a process in place for actually interviewing patients once they're back in the hospital to find out in their own words, tell me about, what challenges you face so that we can do a better job of trying to, design some assistance once you leave this time. And one of the things we found is that if there's sort of that white coat syndrome, where if it's a nurse or a physician that asks, that they don't really get the answer that they feel like patients are just giving them the answers that they feel like they're expected to give. Whereas those that have used PFAC members or volunteers to go in, you really get the whole story. So there's so much value in that. I absolutely agree with that.
Kim, I think Libby had something to share or ask.
Yeah. Libby, are you on mute?
Oh, okay.
Okay, you'll come back.
Come back.
Oh, and this is a great comment from Grace too about using some of the age-friendly ideas too, about taking those models into consideration too. Absolutely agree. Teach back method also absolutely helpful. That's excellent. Okay, let's flip it to the other side now. I would love to hear from other hospital and healthcare organizations, from the healthcare personnel perspective. So what advice do you have as a healthcare professional for others that are looking to engage patients and family members in quality improvement activities? And then, or also, what, now that you've done it, and what were some of what was the biggest fear or challenge that was related to actively getting patients and families engaged in quality improvement activities? And were those fears warranted now that you've gone through it? Erin, go ahead and unmute your line. I see your hand raised.
Hi, I joined a little late, so I apologize if this
Oh.
has already been brought up. But one of my, I think the most important and one of the most important and impactful things that staff can do to engage patients and families is to set up a time to meet one-on-one or outside of an engagement activity. So you develop a relationship and kind of teach the family member what they're going to be walking into and give some background. And then that way, once that familiarity is established, that patients and families feel more comfortable speaking up in a larger group if they say, hey, I know that person, we already talked about this. And it kind of goes along with that piece about pausing and saying, patient or family, do you have anything to add here at this moment? So it's kind of a two-part.
Excellent, excellent. Yes. I've even seen, in the early days of starting up PFACs and having patients start to be engaged, I've even seen where hospitals or healthcare organizations gave the patient family partners, like a cheat sheet of acronyms, or gave them a paddle to hold up that said, wait, can you define that for me, please? And then everyone in the room knew what that meant. Wasn't that, oh, this person has no idea what we're talking about. It's no, we're speaking in, health speak, which is depending on what, that's different in every department in an organization. Let's see here. I'm trying to see the chat. Oh, good. Yes, Joanne, recent re-implementing visiting hours helps involve families more. I'm looking for, it looks like there's a, from Erin. Obviously Erin loves that. Lori says they set up time for their hospital staff liaisons to meet with family before they join the larger group. That's excellent. It helped to build trust. And also you do the cheat sheet of acronyms. Love it, love it, love it.
So this is Grace. I would say that, somebody mentioned like family advocates and rounding, and I actually worked for a psych facility that did that previously. And
Nice.
it really had a huge impact in terms of like putting the discharge plan or even the plan of care in place for a patient. For example, if we were planning to help them do something like recreational activities, having that conversation about realistic recreational activities that somebody, for example, in Alaska could do versus where they're receiving treatment in Texas. So I thought that was really important because it helped the outcome in the long run.
Yes. Oh as I'm an old psychiatric nurse, so I love hearing this, because it feels like behavioral health is one of the areas that we, even though it's probably the area that we need the most partnership with patients and families, it's one where it's really challenging, sometimes just because of the setup of the way that inpatient units are set up and all that. So I love hearing this. Anybody else from the healthcare personnel perspective, or how to build these relationships, anything that's worked well for you? Or how about the second question here? What was those that have done it now, what was the biggest fear that you had before engaging patients and families in your quality improvement activities? And was that fear warranted?
This is Erin. I unmuted. I'm sorry. I should have raised my hand. I think
No, unmute. Good.
I think there can be a fear, like, we involve patients and families in serious safety event reviews. And I think that there can be a real fear of kind of like showing the, underbelly or whatever the bad things that can happen. And so when that decision was made initially to involve patients and families, there was, a lot of discussion about it. Should we do it? Should we not do it? And then it ended up being done, and it was like, worked out really, really well. And now they're always a part of those event reviews. And so I think there can be a fear too about exposing what really, just exposing what goes on.
I completely share that struggle, because I will tell you that, as a former director of quality too, that was my biggest fear. We started this was, oh gosh, we can't let patients know some of the things that really happen. Guess what? They already know. So it wasn't actually a surprise. I mean, awful things happen, but the more transparent we can be, the better. And who better than to tell us their ideas about how to prevent something bad from happening again than those who understand, who are there in the room the entire time and see everything that happens. Those are the kinds of folks that help us to really create actual improvement. Oh, and Ken, yes, that, you know, it goes right into anyone that may have been involved in candor too. There's a few other of these fabulous disclosure processes that, you know, helps hospitals and healthcare organizations to understand, okay, here's the steps that we need to take, because we're terrible at it. I'll fully admit that too. Pat saying that policy gets in the way of patient-centered health outcomes so many times, and we should be willing to challenge the policy. Yes, for improved patient satisfaction and health outcomes. Thinking about, you know, family visiting during COVID. Understand in the beginning, but you know, we know better now. So what can we do with this too? And then Libby saying that, you know, the irony is that as a patient, our fears are present regardless too. And so that the opportunity to create improvement for others is highly motivating. It's highly motivating for me too. So this is fabulous. So I know we are just about out of time, and there were some questions that we had come up too in the registration here too. I think we've talked about many of them, but I'm wondering if there's a question that you had sent in beforehand. If you just want to unmute your line and give us that question, let's see if we can answer them. These, and then I know there's a few back here too. What experiences have you had? We talked about this. Advice for building empowerment. How has your organization adapted to re-engage patients and families? And then the question from Ken in the chat, I'm going to give that to Lindsay about any kind of debrief that's going to go out. I'm assuming yes.
Yeah, absolutely. We'll be sharing the recording out as well as the tool that Kim shared, and I'm happy to kind of comb through the responses in chat as well as, you know, the discussion we've had here to reshare some of those great ideas. That's a great idea, Ken. Thank you.
Empowering family through psychosocial services. Oh, wonderful. You're a child life specialist. Grace, you saved my family for your role saved my family. So an integrative model helps to engage patients and families. The best. We can learn so much from child life specialists, I'll tell you, in the adult world. Right. Well, I think these were just a whole bunch of questions we have. Mine and Nadine's contact information is here too, so you can feel free at any time to, I'm sure I'm speaking for Nadine too, to reach out to us with any questions that might come up, anything that we didn't answer. And I know that we can, hopefully we'll be able to answer anything else that comes up. But thank you so much for what you do from the bottom of my heart. Just the fact that this is important to you is music to my ears. So thank you for being here.
I will say the communication is really excellent. I can't speak highly enough. It's you gave us free reign, and you reel us in if we have to, but it rarely happens. And if it did, it would just be a learning experience.
It would be me needing to be reeled in, so not to worry.
So thank you.
Thank you very much, everyone.
Great. Well, thank you, Kim, and thank you, Nadine. Really fantastic presentation and discussion. So thank you, everyone, for jumping into the discussion as well. Like I said, we'll do a follow-up with the recording and all of these great ideas that were brought forward today. So thank you very much. And I hope everyone can join us next month. Same time, same place. We are going to be joined by Christina Motti, who is from the California Quality Collaborative and Purchasers Business Group on Health in California. She's going to talk about moving toward behavioral health integration and a new tool that they have. So we'll keep on bringing this fantastic content to all of you. And thank you again to Kim and Nadine. I really appreciate this presentation and discussion. So
thank you, everyone.
So long. Thank you so much.
Thank you.
Take care. Thanks, everyone.
Thank you.